Okay, I think we'll kick off this webinar now. So thanks everyone for joining. Good afternoon. Welcome to the Dilapan-S and NICE webinar. So just a quick introduction. I'm Mike. I'm one of the key account managers here at AG Health. And with me, who's just turned the camera on, is Louise. She's one of our product specialist midwives. So both of us will just be giving you a quick run through today to talk about sort of what Dilapan-S is and how it fits in with the NICE guidelines. So just before we start, just because we thought that this has helped us in the past with webinars, if everyone could just keep their mics on mute, that would be helpful. And as well as that, if you have questions, we've got one of my colleagues, Anish, is monitoring the chat. So if you want to just sort of type those into the chat, we can sort of address them at the end in the Q&A. Or if not, if you just want to ask us just a question at the end in the Q&A, that's fine. And then lastly, we will be recording this session. So just if anyone has a problem with that, do let us know and we will stop the recording. Otherwise, we will go ahead with that. In terms of the agenda for today, so we're just going to have a run through of the team here at AG Health, the suppliers of Dilapan, and sort of where our territories are in the country and who in your trust you will be interacting with, as well as talking a little bit about what Dilapan-S is and how it can play a part in your trust. And then we're going to be giving sort of an update on the NICE guideline and how that fits in with Dilapan-S. And then sort of we're going to just talk about how incorporating Dilapan-S into your trust can help both you and the women that you help. And then lastly, we'll just finish with the Q&A. So this is the team. So we have 3 account managers. We've got Aisha, Charlotte and myself. Aisha heads up the West region and Charlotte the East, and that is effectively the UK is, we've split above London, the UK into sort of 2 halves, West and East, and so they cover those areas, and then I cover all the regions below London in the South. Likewise, we have our 2 product specialist midwives. We have Louise and Steph. Louise does the North region and Steph does the South. And we will be putting our account details up at the end if you want to get in contact with any one of us. But now I'll pass you over to Louise, and she's just going to talk with you a bit about Dilapan-S.
Thanks, Mike. Hi, everyone. So I'm Louise. I'm one of the product specialist midwives. So I'm just going to give you a brief overview of what Dilapan is, which I'm sure many of you are aware of anyway. So Dilapan is a mechanical induction of labour product, and it is basically around to help reduce the burden on maternity units. It's a synthetic hygroscopic cervical dilator, and it's made of acrylic hydrogel, which is the same material as your contact lenses. So we know that it's very soft and very safe. So I'm just going to show you what it basically looks like. So this one here is what it looks like to start off with. And this one here is what it looks like and just shows how soft it is once it's at full dilatation. So it is a rigid dilator which absorbs fluid from the cervical canal, and that then gradually dilates the cervix. So it starts off about 4 millimeters in a dilator in diameter and then expands up to 15 millimeters. We do recommend for the optimum results for us to use around 4 to 5 dilators. This is actually used now in over 40 countries. And although it's licensed for 24 hours, there is no real further expansion after 12 to 15. So the optimum time to use it is around 12 to 15 hours before you take them out. One of the real benefits of Dilapan is it's got 3 modes of action, which is really great. So the biophysical mode of action is the osmotic dehydration of the tissue. That then leads to this tissue reconstruction. The mechanical side, that gradually dilates the dilators, which then dilates the cervix and exerts pressure on the dilator, on the cervix. The physiological side, that expansion stimulates a natural release of prostaglandins. This leads to the collagen degradation, which then softens and effaces the cervix. And one of the real benefits of Dilapan is these 3 modes of action means that the cervix can stay dilated then in a dehydrated state, which some hospitals suggest up to 24 hours. So we're able to help with that ward management, and ladies don't necessarily need an ARM straight away. They don't need a bed on delivery suite straight away. So we're just able to help in that sense. What we need to advise is the cervix will be found to be notably soft, stretchy and dilated. So the effacement is a little bit different here than other methods. So this ripening follows a similar process to the natural labour. So it may appear very different in examination. So it's really important that you know what to expect. This is a little example here of one of our induction pathways that we will send you if you do become a customer of ours. This is one of the outpatient programs that we use. So what we recommend here is, and what some of our hospitals use, is that ladies will then come in between 6 and 10 p.m. at your hospitals in a staggered process. They have Dilapan inserted, so if their Bishop score is less than 6, they have Dilapan between 6 and 10 p.m, go home, they're well rested, they stay at home until 12 a.m, so for 12 to 15 hours, then they have Dilapan removed. We do look at whether they're favourable for an ARM or not, and we know that current research suggests that over 90% of these ladies are favourable for ARM just on first round. And then what's really great is Dilapan's now in the new NICE induction of labour guidelines. And what we really want to explain is how we can help ease the pressures on your trust, because we know that induction of labour is on the increase. And one of the first things that we're really going to discuss is that NICE is recommending now that instead of induction of labour at post dates being 42 weeks, is that we're now going to induce ladies at 41 weeks. So we know that that's going to induce the induction of labour rates and induce the workload for everybody. One of the benefits, and many of the benefits of Dilapan, is that will reduce the workload due to a reduction in analgesia needs, no indication for CTG, maternal support and reduce in repeat rounds. There's no immediate need for an ARM, there's no hyperstimulation, so that stops emergency situations. It's well suited for outpatients, so that can be a real cost saving for hospitals, and a patient satisfaction and comfort. So one of our studies found that 79% of our ladies were able to sleep with Dilapan inserted, and 94% of our ladies found that it was an acceptable procedure, so it was comfortable for them. We also found in one of our studies that there was a reduction in caesarean section rate compared to another mechanical method. So this is just showing you what Dilapan can do for your trust. We also looked at the NICE guidelines for pharmacological and mechanical methods and what they recommended. So they recommended that women with a Bishop score of less than 6 to offer dinoprostone or misoprostol, but to consider mechanical option if pharmacological is not suitable or if a woman chooses mechanical option. So we know that Dilapan is more beneficial because it's got 3 modes of action. They stay dilated for up to 24 hours. There's nothing protruding outside the introitus. And we've also found, which is really exciting for us, that a number of our trusts that are using Dilapan have now found a reduction in oxytocin rate. We've found that Watford have gone from 45% to 23%, and Kingston, that used to use prostaglandin, were over 70%. Now they're using Dilapan, they're at 52%. So we're finding those statistics really exciting. Maternal request, that's really, really important. Women's choice is always important to us, as we know. And when they're recommended to have an induction, we feel like they can still feel empowered if they've got the choice of induction of labour product. So this was quite interesting. NICE recommended that they need to discuss that dinoprostone and misoprostol can cause hyperstimulation and that they'd need regular monitoring. With a mechanical option, they won't need that. That's not necessary. So with Dilapan, 95% found the insertion to be tolerable, like I've discussed earlier, and similar or more comfortable than other gynae procedures. And almost 80% could sleep during the cervical ripening with Dilapan. There's a reduction in analgesia needs. So one of our hospitals, they were actually at 80% analgesia for all of their induction ladies. Once they changed to Dilapan, they then went down to a dramatic 15%, and only 5% of those ladies were having paracetamol. They also found a big change in their atmosphere of the antenatal ward, even with the inpatient using Dilapan. And again, there's no protrusion outside of the vagina, so these ladies are able to mobilise freely, which is really important. We have a really good outpatient induction programme, so it was really nice that NICE guidelines were able to put this in. We've got more hospitals using this with us now, and one trust is at 42% outpatient programme. So NICE recommends to consider outpatient with vaginal dynaprostone or mechanical with respect of the women's decisions. We know that that relieves the strains on the wards, and women are more comfortable at home, so it helps increase their oxytocin levels, and they can be with their families. It's also cost saving for the trust, which we all know about. So with Dilapan, it's a mechanical method, so it's not an indicator for a CTG. They're not only if they're just post dates, but even if they're moderate risk. So I've just put an example on these slides here. So not just for maternal request, but for pelvic girdle pain, small for gestational age, essential hypertension if they're well controlled and on medication, diet controlled gestational diabetes. So there are other options for them as well, even though they're not just low risk. And like we also said, they're more likely to go into labour if they're at home in their own environment with their families, because it will help increase their oxytocin rates. Previous caesarean section. They've got here a choice of mechanical methods, which is also advisable, and Dilapan is recommended and licensed for all inductions. So the only contraindication for Dilapan is if they've got an active genital tract infection. So Dilapan does not cause hyperstimulation and won't cause any scar rupture. So women that have had a previous caesarean section that are increased risk of uterine rupture and emergency caesarean section, we can advise them of Dilapan and a mechanical method. And it's also licensed. Intrauterine fetal death. So women have a choice of induction of labour method unless they've had a previous caesarean section. So with Dilapan, we know that it's a gentle mode of action for these ladies. Less analgesia is required if they wanted it, and there's no risk of hyperstimulation. It's also better comfort than other mechanical methods, and we're also giving them a choice, which is really, really important. Now I'm going to pass you on to my colleague Mike, and he's going to explain further how we can help with Dilapan.
Thanks, Lou. We're just going to swap over sharing the presentation here, because we found that that's been a lot more effective than if we were to take control and do it that way. So, everyone able to see that? Are you able to see that, Lou? Yeah, okay. So I'm just now going to briefly discuss how we can help you as a trust support your women. So just a quick run through of what sort of Lou has already been saying in her presentation, but just to sort of collate it all together and sort of clearly show you how the women in your trust can be supported through the use of Dilapan. So the first thing to start off is we found that our patients have had a high patient satisfaction with Dilapan when compared to the balloon catheter, and that's both in first-hand experience and in subclinical papers as well. And the one thing that we've also found, or our midwives have found as well, is that there is peace of mind for the women returning home with Dilapan inserted. And one of the reasons for this is, as Louise already mentioned, is there is nothing external from the body. This Dilapan is all internal. So it's often a lot more comfortable for these women to go home in an outpatients program and not have anything extruding from the body. Secondly, there are no contractions when it comes to using Dilapan. So obviously it supports the release of natural prostaglandins. However, there's no excess of prostaglandins, so there are no early contractions prior to labor. And this means that there is minimal pain relief required. As Louise was saying earlier, we found only 1% of patients needing opiates. So with comparing this to sort of using the prostaglandin route, there's been a lot less pain relief required. And on top of that, there's a reduced need for CTG monitoring. So this helps with the outpatients program, but it also means that the women, they don't have to be coming back into hospital to have this CTG monitoring to check on the fetal heart rate. They can go home rest assured, knowing that with the action of the non-pharmacological Dilapan, that they won't have to come back in to check the fetal heart rate. And we've just found that because there is a reduced risk to mother and baby, that the women are often in your trust will be relieved to use Dilapan. And as Louise was saying earlier, we believe that using Dilapan supports this natural onset of labour. As evidence from our audits have shown, there is a reduced use in Synto, and therefore we believe that Dilapan helps support that natural onset. Secondly, because of this gradual dilation that we mentioned between 12 to 15 hours, it makes the whole process of cervical ripening a lot more predictable. And that means that the women that in your trust will be able to know sort of exactly when their cervix will be ripened. And it does, but this doesn't mean that they necessarily have to be ARM'd immediately after that 12 to 15 hours. Because of that dehydration of the cervix, it does mean that there is time for ARM if the right situation is not in place for the labour process. And this can also be reassuring. With Dilapan inserted, the women are able to continue to mobilise, and actually it's encouraged as part of the process. And this means that they can continue to do their day's activities. The only activities that are contraindicated, are bathing and sexual intercourse. So that is how Dilapan can help support your women. I'm just going to quickly discuss how Dilapan can support your trust, especially the staff when you guys are under pressure. So first of all, Dilapan is licensed for use with all patients. The only contraindication is those with an active genital tract infection. But apart from that, you can use Dilapan and it is licensed for any other patient. There's also, when using Dilapan, there is no increased risk of infection. And that includes during SHROM as long as the appropriate methods are taking place to disinfect equipment. There's also no risk of hyperstimulation. I mean, I've already said this, but because there is no risk of hyperstimulation, it can ease the pressure on you as clinicians because you won't be worrying about your patients, especially if they are going into an outpatient program. And as you've heard from Louise already, this is a product that is optimized for outpatients. And because you will be seeing more patients you will be having more women in outpatients. This means lower admission rates, which means more space on your delivery suites and on your wards. And again, there's there'll be reduced CTG monitoring. All of this saves time and costs. And the other thing we'd like to hit home is because there are lower need for analgesias, the women on your wards will be happier, and therefore we believe you as staff will be happier when using Dilapan. Another point that we want to make is that some people have this misconception that Dilapan needs to be inserted by doctors. Actually, it doesn't need to be, and we actually encourage some midwife-led programs, and it can be inserted digitally. This can be done on the bedside, and they do not need to be in the lithotomy position. If you have a ultrasound wedge or something that can elevate, then digital insertion on the bedside is very easy to do. There are also fewer indications with vaginal exam as well. And then lastly, as we were discussing earlier, there is because of this dehydrated cervix, there is no need for immediate transfer for ARM, and that once the cervix is ripened, and it also means that it gives you time after the ARM has been completed as well, before the labour process. So it works both ways. And lastly, I talked about how the gradual dilation meant more predictability for the women in your trust, but it also means that you are able to manage your wards more efficiently, because you are able to predict the outcomes of the circle ripening, and therefore you can manage the beds to your liking. And we believe all of this together, the combination of all of it, means a better atmosphere on the wards. If staff are utilising Dilapan in the correct way and in the right way, then we believe that the atmosphere on the wards will be improved. I'm just going to quickly discuss, you might be thinking, what about other mechanical methods? Well, we'd just like to quickly go over just some of the evidence of Dilapan-S compared to balloon catheters. So this is a randomized controlled trial done by Sada et al. In 2019, and it compared Dilapan-S to the Foley's balloon catheter for cervical ripening. And as you can see, Dilapan-S on the graph has a more effective rates of vaginal delivery, but it also, more importantly, has a significantly better patient satisfaction. And this is one of the things that we'd like to for you to take home today, is that the women that were using Dilapan when compared to the balloon catheter had better sleep, were able to relax and perform their usual daily activities while it was inserted. The other advantages is that it's FDA approved, it has a safe profile, no protrusion, and it doesn't need to be kept under tension, unlike with the balloon catheter. And all of this adds up to better and improved patient satisfaction. And then this is just one more study that looked into osmotic dilators versus balloon catheters. And this was a retrospective observational study, but it still found that when using Dilapan, there was a increased safety when compared to the balloon catheters. There was a similar vaginal delivery rate. However, when using Dilapan, there were lower needs for instrumental vaginal deliveries. There was a lower rate of low APGAR score women. There were lower volumes of interpartum hemorrhage and lower frequency of postpartum hemorrhage as well. So we just sort of like to point out that using osmotic dilators does have a better safety profile for women. And then just briefly, we've got one slide just on sort of the cost considerations. As you can see here, when compared to Propus and Prostin, Dilapan-S is slightly more expensive. However, we would like to point out that there will be cost savings when using the Dilapan, because we have a success rate of around 90% with cervical ripening. If you compare that to Propus and Prostin, they have a lower rate. So that means that you need more product when you go for second line treatment. So because you're less likely to be using Dilapan-S a second time, you will be saving costs. And we've just done a quick example here for what those costs would look like for a 6,000 birth unit in a year. Now, this isn't even including other variables that can play a part, which is the outpatient program. If you employ an effective outpatient program, you'll see further cost savings. And then Dilapan can help with the length of admission, reduced need for CTG monitoring, as we discussed, a lower need to give out analgesia, and you won't have to give the medication to combat hyperstimulation. So all of these things can add up to help lower costs on your trust. And then just briefly, I'm just going to go through what working with us looks like. So obviously I'm one of the key account managers, and Louise is one of the product specialist midwives, but effectively my job will be over the first 4 to 6 weeks to give introductions and initial presentations on Dilapan. We can give you support, standard operating procedures and patient leaflets. And when we're waiting for approval from your maternity governance, then after that we have that approval, then we can introduce one of our product specialist midwives. And from there, they can sort of discuss with you and tailor a training plan to your needs, as well as organising the in-person training and the sharing of more resources. And then after that, we can start the trial. And then once the trial has begun, it's a partnership, and we hope to collect and share data with each other, and we can then review that data to optimize outcomes for your trust. And we can create business cases and update the guidelines for your trust specifically based on that data. And all of this together over the course of around 4 to 6 months, should allow for you to have Dilapan-S as standard practice in your trusts. And we'd like to point out that we are a small company that's dedicated to helping support you guys once Dilapan-S is on your wards. We will offer and update your training to your needs as you go along, and our product specialist midwives are always at hand to help if there are any issues. Just quickly, this is our portfolio. So we are actually specialists in obstetrics and gynecology. So you might have seen our other products, Amnisure and Lamella. These are diagnostic tests for SROM and preeclampsia. And then just to briefly touch on Dilapan one more time, is with my colleague Anish is just going to put in the chat a link to Dr. Zahar's presentation from the Cardiff Maternity Festival. So if you want to hear what a clinician has to say, she's the obstetric lead at Cardiff, and she gave a nice talk on how Dilapan-S can work and function in the trust. So that's it from us. These are our details on the screen now. As we've said, we've divided the country into regions. So if you would like any to ask any questions, please do refer to the account manager within your trust, and we'd be happy to get back to you with any queries. And yeah, so at this point I'm going to ask Anish, do we have any questions in the chat?
Yeah, hi Mike.
Hi.
We have one question in the chat, and I think this would probably go to Louise. So the questions come through from Gillian from Gateshead. So Gillian's asked, how do we proceed should the woman begin to labour during the period of Dilapan insertion?
Oh, that's an excellent question. So if the lady starts to labour and she becomes their regular contractions and she starts to dilate, then obviously the dilators have done their job, so we can remove them. But certainly if she's just in the early stages of labour and they're mild contractions and they're not really doing anything to the cervix, then we're able to keep them in, but we just monitor the lady. But certainly if she becomes active labour, we can remove them because Dilapan's certainly done its job. Hope that answers your question.
So Alice, are there any other questions?
So there are no more questions in the chat. We might have one more coming through. I can see someone's typing, but nothing just yet. But feel free to come off of mute and ask a question if you prefer to do that.
Yeah, exactly. So yeah, if anyone wants to ask a question, please do.
Can I? Hi, I'm Tejo from West Hearts. Quickly ask Louise. So the effect will last for 24 hours. So if we've got delays in getting into our delivery suite, would we then reuse Dilapan, or would we have to assess the women and decide what course of action to take after that?
Yes, you can. So if you wait the 24 hours, so depending on how long the ladies are waiting for ARM, because I know there is a little bit of a backlog with lots of trusts at the moment with the increase in induction. So you can insert more dilators if that's what your need is. Obviously there's a reduction there's less than 10% of ladies that would need a second round of Dilapan, but we know that because of the dehydration of the cervix, that's only going to last a certain amount of time. So there is going to need to be another option if these ladies are waiting any longer than 24 hours.
Thank you.
So we do have one more question that's come through in the chat box. Is there any statistics on how often Dilapan falls out or becomes dislodged?
Do you want me to answer that, Mike?
Yeah. So, well, I was just going to quickly say that I don't think we have any specific statistics to hand as of yet, but then I'll just sort of let you answer on sort of what happens and if they do fall out.
That's absolutely right. Yeah, we don't have any statistics, unfortunately, but they can fall out. They can fall out if they're not inserted through the internal os. So sometimes we need to make sure as a practitioner that we insert them through the internal os. It's really important that you do feel when you insert them that there is a little bit of resistance, that sometimes when we insert them that we don't feel that resistance. So sometimes you can get a little bit of funneling. That could be a reason for them coming out. And if you insert 5 dilators, you may often get one dilator that's in the middle of the dilators that doesn't use the cervix to dehydrate, so to get that fluid basically, and that can sometimes fall out. What's really, really important is if you're unsure, so a lot of trusts that we use, they will have 2 people with them when they insert them and 2 people on removal, so that they can countersign whenever somebody's inserted them and removed them. If you're unsure for any reason how many have been inserted or removed, they can be found on ultrasound or MRI, and whether the ladies are in labour or not, it's really important that we find out where these are. A lot of the time they're in the vagina because they've just slipped out, or if these ladies are outpatient, then we need to remind them and make sure that when they do go home, and if they feel they've fallen out and maybe they've fallen down the toilet, that either they take a picture of them or they let us know, or they bring them in with them if they have fallen out. But they don't fall out very often because obviously they're dehydrating the cervix, so that's where they stay. Hope that answers your question.
Yeah, so we have a couple more questions come in. Are there any religious or cultural implications for the use of Dilapan?
Not that I'm aware of. Lou, do you have anything to say on this?
No, not that we've heard of.
Yeah, this is actually a question we haven't had before. It raised some interesting sort of thoughts, but off the top of my head, there are no sort of cultural implications that come with using Dilapan.
Okay, brilliant. So we have no more questions in the chat box, but we do have a hand raised. So I believe, is it Kate Conway? If you want to come off mute and ask your question. Sorry, Kate, you're on mute. We still can't hear you.
I was just thinking maybe if we use this time just to maybe answer one of our other frequently asked questions, which is, and I'll sort of ask this to you, Louise, if you don't mind, is can you use Dilapan if a woman has already schrammed?
Yeah, that's a really good question. Thanks, Mike. Yes, you can. There's no indicator why you can't. However, what we do recommend is that you use a speculum and you use an aseptic technique. The other thing that we recommend is for a 12-hour maximum, because obviously we need to be really important with the risk of infection when a lady's schrammed. But Medicine, so our manufacturers, have advised us there's no indicator for you not to use them for a lady that's schrammed.
Yeah, great. That is one of our frequently asked questions. Kate, do you still want to ask that question?
Can you hear me now?
Yeah, we can hear you.
It's not actually so much a question. I'm a clinician. I'm the matron for antenatal and gynecology services at the Royal Surrey in Guildford. We've been using Dilapan for a year now. We finished our trial and we're about to move to it being our main method of induction of labour. I just wanted to offer some reassurance, if that's okay, in that it is really different to how you manage induction of labour currently with prostaglandins, and it is really fiddly to start with, and it does fall out and you do get it in the wrong place. to begin with, but as midwives in particular, as the technique improves and you get it and you're inserting it more, your success rate goes up, and then you start to see the outcomes and the results. And I really highly recommend everybody has a go and has a trial and sees how it goes as a basic. It really does make a massive difference to women's experience of induction of labour. And if you want to change how your induction of labour pathways go, then Dilapan really is the only way to move forward, because it's the only way you're going to stop women jumping the queue because of hyperstimulation or fetal distress. And the results from our trial were really quite significant in that respect, in that we had no category 1 sections, we had no hyperstimulation, we had no fetal distress, and we had no failed inductions either. So just
that's pretty good to hear.
Thank you.
On that note, I was going to maybe just sort of propose a question to the people still in the chat, and I was just going to sort of ask you guys, do you think that there is anything about your current protocol that the NICE guideline update has prompted you to reflect on? If does anyone fancy answering that question? If not, it's no problem, and we'll probably that'll bring the webinar to a close, unless there are any other pressing questions.
Sorry, Mike, there is one question or comment that's just come through. So Julie's asked a question, but the question's directed to Kate. So Julie's asked Kate, so thanks for sharing your experience. Would you recommend a smaller team is taught on how to undertake insertion rather than teaching all core midwives? So I suppose Kate can start answering that question if she can, and then Louise, maybe your thoughts on that as well as.
Yeah, I mean, we started with a small team of antenatal midwives who we trained to start with, and now that we're moving to it as our main method of induction, we're training all our coordinators, all our senior midwives, and then we've got a year's programme as part of our mandatory maternity training to teach everyone, with a plan to move to a complete outpatient model in the summer next year, starting our inductions in the hubs rather than bringing women into the hospital at all.
Brilliant, thanks, Kate. Louise, I'm not sure if there's anything you wanted to add on that, considering you travel half the country and do some of the training.
Absolutely, and I totally agree with Kate. I think it's really important to have a small core team to initially start Dilapan, and certainly when you're doing a trial of it, and then training more staff and more healthcare professionals as you progress with Dilapan and as you get used to it. So certainly I'd just second what Kate has just said. Absolutely.
Excellent. There's nothing else in the chat.
Okay, great. I thought that, so what will happen is me and Louise will just stay on for the next 5 minutes. Obviously, you're all busy people. I'm sure you've got places to go. But if you do want to sort of wait and ask us any more questions, we'll be here for you to answer, for us to answer them. If not, yeah, thank you for joining. I hope it's been helpful. And yeah, again, with the people on the screen, contact any of us account managers if you've got any further questions. Either call us or via email, and we'll be sure to respond quickly. So thank you.
Thanks, everyone.